Welcome back to our channel. In this video, I will briefly present a surgical procedure that is generally recommended for young patients with cartilage damage in the knee. The surgical procedure in question is called osteotomy and is usually performed on the tibia, but although less frequently, it can also be performed on the femur. In this illustration, on the left, you can see the mechanical axis in a person with good knee alignment, while in the middle figure, the mechanical axis represented by the green line passes much further inside. In other words, we are looking at a so-called varus knee, which is the opposite of the valgus knee you see in the figure on the right, where the mechanical axis passes further outside. The purpose of the surgery is to make an incomplete cut in the bone and slightly change the mechanical axis, which is the axis through which the body's weight passes, to move it from the area of greatest cartilage damage to the area where the cartilage is healthier, as I have tried to represent in this image, in which the yellow line, which is the original mechanical axis, will be moved more laterally, and in particular where the red line passes. The surgery is ideally recommended for patients under the age of 55 who are not obese, are not heavy smokers, and have a mobile knee. In the vast majority of cases, the operation is offered for varus deformity. In this case, it will be the inner part of the knee that will have the greatest degree of cartilage wear, as shown by the red arrow, while the outer compartment should still be in good condition, as shown by the blue line. As we have already mentioned, the aim of the operation is to slightly shift the mechanical axis in order to distribute the body weight passing through the knee more evenly. In order to plan the degree of correction, it is essential to take X-rays not on the X-ray table, but while standing, in order to understand how the knee behaves under load. The X-ray must be taken in such a way that the head of the femur and the ankle can be seen in a single image, allowing us to calculate exactly how many degrees of correction we need to achieve. It is also important to perform an MRI scan, which will provide useful information on the condition of the knee cartilage and help us understand whether there are any deep cartilage lesions that may require a surgical approach at the same time as the osteotomy. In this regard, I invite you to watch the video on the treatment of osteochondral lesions, which you can find on my YouTube channel and on my website. As for the surgery itself, it can be performed under general anesthesia, or better still, under spinal anesthesia. In the latter case, an injection is made in the back to numb only the leg to be operated on. In this photograph, you can see the imaginary direction of the cut in the tibia, marked with a marker pen. As I said, the cut is incomplete and starts from the inner surface of the tibia at an angle, stopping about 1 centimeter from the lateral surface of the bone. Once the bone has been cut, we use chisels, which are inserted one at a time to gradually open up the osteotomy area. At this point, we can use a special instrument that allows us to open up the osteotomy area with the exact gradation that we have planned on the X-rays. In this short video, made on a plastic model, you can see how the graduated instrument opens the osteotomy area, rotating practically on the area of bone at the opposite end that we have not cut. Once the planned correction has been achieved, we can stabilize the bone with a plate and metal screws, which serve to maintain the correction over time. Over the following months, new bone will form and gradually settle in the area where we performed the osteotomy. After the operation, you can go home after 2 or 3 days. For the first 3 weeks, it will be important to put only a small percentage of your weight on the operated knee using 2 crutches. which will also be necessary after the 3rd week. However, starting from the 3rd week, you can begin to put your full weight on the ground, provided you do not feel any pain. From the outset, it will be very useful to use an ice pack several times a day, but for no more than 15 minutes at a time, to reduce local inflammation and therefore also pain. For the first 6 weeks, you will need to take prophylactic measures against thrombosis with low molecular weight heparin. These are injections with an extremely small and thin needle. Anticoagulant tablets are also available on the market, but I personally do not recommend them because they are much more dangerous medications. You can only shower 2 weeks after the operation when the scar has healed well. Waterproof plasters are available on the market, but personally I don't trust them very much. Unfortunately, if water penetrates the wound, there is a risk of infection, and I don't like to take risks of this kind. This is the patient whose operation I showed you pictures of. In this case, we are 3 weeks after the surgery, and the patient has just started to put practically all her weight on the ground with little pain and with the help of 2 crutches. The same patient is now 6 weeks post-op and is walking quite well, without pain, without using crutches, and without limping much. Obviously, surgery has risks and complications that I invite you to discuss with your surgeon. I will give you a summary of these, bearing in mind that the most frequent risk is having to remove the plate and screws, which can cause discomfort in almost 50% of patients. However, I recommend postponing the removal of the plate and screws for at least 12 to 18 months after the operation. Thank you for sharing this video and for subscribing.